Hello, hello. Good morning, good afternoon, good evening. If you're expecting to see Robbie today, you're in disappointment, but we are replacing Robbie with Ravi and myself. So hopefully it'll be a good case. My name is Jazz. I'm one of the CP Solver members, and I'm here with Ravi to be discussing a case that Aaron is going to present. Before I give it to you, Ravi, Aaron, do you want to introduce yourself, where you're joining us from, and a little bit about yourself?
Sure, yeah. Hey everyone, I'm Erin. I'm a second year medicine resident at Baylor College of Medicine in Houston. Did my med school there as well. I've been to a couple of the clinical problem solvers online morning reports, but this is my first time presenting. I love our program's morning report, and yeah, just very curious learning more about how it's done in other institutions and learning more about practice styles in other institutions too. So I'm very happy to be here. Have a case that I really like. Excited to share with you guys. Was someone else going to introduce themselves, or should I get started?
Yeah, Ravi, do you want to say hello?
Oh, yeah, sure. Thank you. Sorry, I was just typing in the chat. Andrew was just said a very pleasant comment, so I had to return the favor. Yeah, we couldn't leave CPS VMR empty this morning, so I asked Jas, and he did the honors to co-facilitate. And so we have a VMR. We have Erin with a case, so very excited. So Erin, tell me, what do you plan to do post residency? Any area of interest?
Yeah, I'm hoping to do infectious diseases, so that's sort of what my
Wonderful. Wonderful field there. Yeah, absolutely. We love infectious disease here. We've had numerous cases, and yeah, ID tends to come up quite a bit. And I would say CPS VMR has challenged me and a lot of others with a lot of different presentations of infectious disease. So wonderful field. So we get going, deploy the whiteboard, and
Let's just make Vijay co-host. It's not letting me make him co-host. Can you do that, Ravi? There you
okay,
go.
there we go, Vijay. Sorry about that.
All right, so we're ready to get started with our case.
Just a minute, a small glitch.
Sorry, guys. There's a little bit of lag on my part. So I hear a little, I think I hear someone say that I can get started, but if that's not true,
Yeah.
let me know.
Yeah, Erin, I think, yeah, go ahead, get started.
Okay.
The whiteboard will be deployed in a moment.
Yeah, I'm here at our VA and our Wi-Fi is a little spotty, so I'm gonna just if anyone has any comments, or if I'm talking over anyone, just please let me know in the chat. Okay, so our chief concern today is, Doc, I'm just not feeling right. We have a 74-year-old gentleman. He has a history of HIV, which he's had for like 4 decades, on Atripla, and his last CD4 count in our system was from 5 years ago. It was 392. But he says he's compliant with his ART. He also has diabetes, A1C 7.8, hyperlipidemia, hypertension, chronic lower back pain, which he's had for the last like 20 years. He's coming into the ER because he just hasn't been feeling right in the last actually like 2 to 3 weeks. So he was in his normal state of health until about 2-3 weeks ago, when he started to just feel really like tired and fatigued and like weak all the time. So no like specific focal weakness, but just overall didn't feel like he was himself. And usually he does all his ADLs independently, but he said that he was having just trouble getting through the day, doing all the normal things that he does. And this has been getting worse every day in the last 2 to 3 weeks. And then 2 days ago, he woke up with acute like bilateral side pain. And and then was having like some difficulty like getting out of bed and walking. So again, kind of on the continuum of this weakness and malaise that he's been feeling, but he did notice it get acutely worse 2 days ago when he woke up. Review systems wise, he has had like some subjective fevers, but never noticed, you know, his temperature. Like he never took his temperature, so he didn't know exactly what temperature it was, but he has noticed some subjective fevers, some just malaise, weakness, but pertinent negatives are like no headaches, no nausea or vomiting, no abdominal pain, no dysuria, and no recent sick contacts, anything like that. So I'll stop there for the first aliquot.
Aaron, I just want to say what a beautifully written out aliquot and everything. I just want to clarify one thing though. You said woke up with acute bilateral side pain, so like flank, or just wanted to clarify that.
Yeah,
Okay.
flank. Like not in the center of his back, but on both sides, like kind of a yeah, like I would say flank.
Okay. Ravi, do you want me to go first, or do you want to go first?
When I
Okay.
saw the patient, I was able to. Wait, go ahead.
Okay, sorry, no, go ahead. What were you gonna say, Aaron?
Oh no, I was just gonna say, I'm sorry, when I saw the patient, he just kind of pointed at it, so I actually didn't really like specifically figure out the location, but I would say bilateral flank pain is the correct term.
Okay. So if I begin, I guess the way I would paint this picture is this is a 74-year-old gentleman with immunocompromise that's presenting with a subacute onset of generalized fatigue, acute onset of bilateral flank pain with subjective fevers. So I think to take a step back and say, you know, what's located in the flanks. So in the flank region, you have your paraspinal muscles, you have the kidneys, retroperitoneal. What would cause acute bilateral flank pain that's related to the kidneys is hard for me to really describe. Now, there's always could be that endocarditis phenomenon where you're having, you know, vegetation's flicking off the valve and going to the systemic circulation, leading to acute kidney infarct. But you would imagine it would be stepwise, meaning patients saying that, hey, I started having this acute flank pain bilaterally, and then, you know, oh, sorry, in one side, and then the next day I started having that. The other thing that could make sense is kidney stones, but, you know, and there is a HIV medication, I believe ritonavir, you know, that can cause an increased predisposition to getting kidney stones. So that's one way. Can you spike a fever with kidney stones? Not directly, but if those kidney stones can get infected, then yes, it is possible. And I think HIV patients, before we go into the esoteria world, you know, just common things being common, they're more likely to develop just your garden variety infections, whether that's cellulitis, whether that's urinary tract infections, pneumonias. In fact, HIV patients, it is a direct, like an independent risk factor for cancer, specifically lung cancer, even when you control it for them having that population having a little bit higher incidence or prevalence of smoking. So they have a lot of risk factors that unfortunately comes with the diagnosis of HIV. So for now, I would say the sudden onset makes me concerned for an infection, pyelonephritis, kidney stone that got infected, that is now causing that flank area pain. And the subjective fevers, I feel like, you know, a patient that's immunocompromised, even if they have low-grade fever, that's enough for me to pause and say, you know, are we missing something that could be ominous in nature? So I'll turn it over to you, Ravi, for you to fill in any gaps.
Great job, Jess. I think there's a lot to unpack here, but if you look at the whiteboard carefully, there's a lot of things that are highlighted in red, and I think I would integrate this into formulating a problem representation. And so the HIV definitely is key, because with HIV, you open the door onto multiple different opportunistic infections. Is there a signal for infection here? At this point, the bilateral side pain could be a clue. Could it be a harbinger of something related to the spine, to the nerves, to the muscles, then to the organs you mentioned? Bilateral renal associated pathology is very unlikely. And I guess the aorta is also in that region. But then there's difficulty getting out of bed. So I kind of wonder, with our geriatric population, 74 years of age, you have to wonder, getting out of bed is usual at this time, and at this age. It can be difficult in regards to, is there arthralgias, myalgias, osteoarthritis? Usually you'll have pain maybe in the joints less than 30 minutes, but usually the pain would get worse throughout the day. So I'm not quite sure. Would need some elaboration with this difficulty getting out of bed. Is this acute bilateral side pain limiting motion? I would kind of look down the pipeline and worry about falls, and falls in this age we have to worry about, because that would be a significant risk for fractures and other signs of frailty, decubitus ulcer formation, malnutrition, and so on. So we do need to look closely. But what's interesting, the chief complaint that Erin just mentioned, doc, I'm not feeling right. And when somebody mentions, I've learned over a period of time to really listen to the patient, because what they're telling us is a story. There's something wrong. Maybe they can't pinpoint, or maybe this condition isn't allowing them to really tell us where the problem may lie. So we need to do our due diligence and listening to the patient, and also then focusing on where they're indicating they're having trouble. So right now, HIV overlapping, if we sort of make Venn diagrams, fatigue is very nonspecific. It could be part and parcel of this. And then subjective fevers. Now, does that open the door to infectious disease? And like I'd mentioned earlier, HIV, many associated opportunistic infections. So we do need to know, though, this patient being on medications, is the CD4 count appropriate? And if the CD4 count is diminished, then opportunistic infections must be considered in working up this patient. I mean, right now there's no signature of, say, a PJP or TB, but we probably have to carefully examine the patient and then test for these opportunistic infections. We haven't looked at the meds yet, but polypharmacy at this age I've had geriatric patients have trouble with mobility due to polypharmacy, so we have to be careful with the medications. And we also had mentioned, I think Jas mentioned, muscle disorders too. So some of these meds could cause myalgia, rhabdomyolysis, and so on. So there's a lot to consider at this point as we unpack this first aliquot, but just a few things that crossed my mind. And there is chronic lower back pain. So is this acute on chronic lower back pain? I'm not quite sure, but I'll wait for more information from Erin to see where I can really focus in on. Back to you, Erin.
I really love the discussion. I just wanted to highlight an excellent point that Ravi made about just how difficult it is to collect history sometimes. And, in simulated case presentations like this, we have some sort of neatly packaged, representation of the patient. But I will say one of the reasons why I personally love this case so much was because, in real time, we were just learning so many different things, going back to ask the patient. And he was just very vague about his symptoms. And so asking very pointed, specific questions was how we eventually got to the diagnosis that we did. But I just wanted to highlight that really excellent point. And I think that's what makes internal medicine fun, and especially ID. So I'll keep going with some more information. So you asked a little bit more about his medical history. So the ER that we're at right now is actually not where he usually gets his care. His PCP and his ID doc are all private doctors on the outside, and we're at a VA right now. So he says that he has had HIV, but he follows with the outside doctors. He takes his ATRIPLA, which is his ART, every single day. He doesn't know what a CD4 is, but the last one we have in the system is 392. So at this point, we're still cooking. We're still waiting on the new CD4. He does have a history of kidney stones. This was about 15, 20 years ago. He had to have some kind of procedure for it, but he doesn't remember exactly what. Hasn't had any kidney stones since then. He said 40 plus years ago when he was in the military, he had some kind of lung injury and a procedure that he doesn't remember either what it was. And then he had a remote shoulder injury also from the military, some kind of tear that got repaired. This was 30 plus years ago, and he has no hardware that he knows of. Family history, he's unsure. His parents died when he was really young, and he doesn't really know what kind of medical conditions they had at the time. Home meds, so he's on the ATRIPLA, which is a 3-drug regimen of efavirenz, emtricitabine, and tenofovir. He's on losartan, hydrochlorothiazide for blood pressure, statin, atorvastatin 20, and then he's on glargine 20 BID for his diabetes. Social history wise, he lives alone. He usually completes all of his ADLs by himself. His son comes by about once a week to help lay out his medications and help him around the house, but he can cook, clean, drive, everything by himself. He's never used any recreational drugs and never used any injection drugs. He was a past smoker, 20 pack years, but quit 25 years ago. So he smoked like in his 30s and 40s. And then recently, no new sexual encounters. He has not been sexually active for the last 10 years, but he did acquire HIV from, sexual promiscuity back when he was younger, not from any needles or anything like that. No recent travel. He's pretty much been in Houston for the last several decades. Doesn't really like to leave town. No significant occupational exposures and no recent sick contacts. Let me see if there's anything else. Yeah, so we'll kind of stop there for a short discussion too.
Yeah, I'll kind of take a first stab at it, but Aaron, remarkable history. I really love that you have documented his functional status. It's always important when somebody presents like this, ask questions like, what do you do on a regular day? How were you 2 weeks before you had this not feeling right symptom or this feeling? So you want to get that information to be able to understand how much they've deteriorated from their baseline. So this is somebody who is fully functional, completing all their activities of daily living by themselves. And then also a remarkable history, because I assume this is a veteran. You're in the VA, right, Erin? And so
yes.
Always have tremendous respect for our veterans, and he suffered quite a bit of trauma from when he served. And then just combing through the medications to see he's taking his antiretrovirals, so triple regimen. CD4 count is last noted to be appropriate. And then you have to wonder, we've had many cases on CPS where somebody's on an anticoagulant, but they're not taking it the right way. Or maybe they're not at therapeutic range because of weight and other confounders. So you always have to caution this as well. We did have a case probably 2 years ago, where a patient was on antiretrovirals and actually was not taking it. So the last aliquot they mentioned, patient's not actually taking it and actually had PCP pneumonia or PJP pneumonia. And looking through losartan and then HCTZ, could this cause any issues? I guess HCTZ for somebody 74, I tend, it's first line antihypertensive, very good as part of the A+C+D regimen. But I tend to back off at diuretics just because as you age, the thirst mechanism wanes. So it could be rather volume depletive in patients. And then not to mention metabolic disorders can happen. Say this patient has a spell where they're infected and they're still taking HCTZ, so it could really aggravate any pre-renal azotemia on top of sepsis. And then atorvastatin, you always wonder about its effects in regards to rhabdomyolysis or statin-induced muscle toxicity. And just to sort of go through the two mechanisms, there's the statin-induced direct myotoxicity that you can have, something called SAM, so statin-associated myopathy, or you could have the real nefarious version of this, which is immune-mediated necrotizing myopathy, and that's through the HMG-CoA reductase antibodies, and that's actually the more aggressive form of this. So you wonder if, although the patient's not mentioning muscle pain or anything like that, but with this back pain, muscles, significant muscles, usually the legs are where you have a lot of muscle injury because they're the largest. I guess the quadriceps are the largest muscle groups that you have. So a lot of rhabdo and injury would happen in that area. And the patient's not mentioning that there's any pain in the legs. But just looking at the med list and thinking about contributions, we talked about polypharmacy. And in addition, patient is a diabetic and being on glargine, hypoglycemia, and is there any diabetic associated complications or sequelae? Diabetic neuropathy could also cause difficulty with getting out of bed. So I'm just trying to relate that and not feeling right. Would this patient meet the criteria for Whipple's triad? Not sure. Definitely getting a glucose will be helpful. But I think I'll turn it over to Jas and see if he has anything to add.
No, not much. I feel like for me, I would kind of want to summarize like what we have so far. Like I think you know, when we think of let's just think about acute kidney injury that we see so many times, rarely do they present with flank pain. So I agree with you what you said in the first aliquot, Ravi, that this is less likely to be the kidney in particular. Could it be the ureters or something, or in somewhere in the GU tract that might be referring back to the pain? Sure, but I think I'm more inclined to say this is more MSK or paraspinal muscle related that's causing sudden onset flank pain. And it's interesting that he does have history of kidney stones with this possible procedure. We don't know how long this procedure was, but given his immunocompromised state, and what I said in the chat earlier was anytime a patient says they're not feeling right with fevers, I think of infection, bacteremia, and is the flank pain just the flank pain that we get, or like the muscle aches that we get when we have an infection, whether it's viral or bacterial. And that just might be, we're putting too much emphasis on that. I think the sudden onset can definitely indicate like a recent injury, but I think taking into the patient's initial chief complaint and taking into the patient's background of immunosuppression, I would still very cautiously want to rule out infection first. And then his smoking history obviously puts him at risk for cancer, but I don't think this has a very strong illness script for that right now. So with that, Aaron, I'll pass it back to you for the next aliquot.
Yeah, sure. So I'll give you some more objective data now. So I saw him down in the ER. His temperature is 99.9. Blood pressure is 90s over 50s. Heart rate's in the 110s. And he's breathing about 26 times. And I personally did count this because he looked very uncomfortable. He's satting 95% on room air though. On exam, again, looks very uncomfortable. He has like mildly increased work of breathing. He's taking kind of shallow breaths. He is a little diaphoretic as well. Anecteric, and he has moist mucous membranes on the HENT exam. Cardiovascularly, he is tachycardic, but he has a regular rhythm. I didn't hear any murmurs. Pulmonary, his lungs are clear bilaterally, but again, he is dyspneic and tachypneic. His abdomen is soft, it's mildly distended, but there's no tenderness in the anterior. Posteriorly, there is CVA tenderness bilaterally. But there is no point spinal tenderness, no step-offs in the spine, no visible erythema in the back. His extremities, he does not have any edema in his extremities, no new rashes. They're warm. And then neuro-wise, he's ANO ×4. And psych, he is appropriate in his mood and affect. And I will say overall, he has a little bit, his legs and his arms are pretty skinny relative to his abdomen. A little bit of like lipodystrophy that I see in him. I will give you some labs. I know that's a lot to unpack, but I'll give you some basic labs, and then the next aliquot, I'll give you some more advanced labs and imaging. So some basic labs, we were able to get the CD4 back pretty fast. It was 296 with the viral load of 30. The white count was 15.5 with 83% neutrophils. Hemoglobin's 13.8. Platelets are 168. Lactic acid's 2.4. B-NANCP is 155. And then on the BMP, we have a sodium of 128, potassium of 3.2, chloride 99, bicarb 19, BUN of 26, and creatinine of 1.27. The last baseline was, again, from 5 years ago, is 0.9. Then his liver enzymes are all pretty normal. And then I'll give you guys a UA. He has 2+ nitrites, 500 leukocyte esterases, 24 red blood cells, and 82 white blood cells.
Is that the end of the aliquot, Erin?
Yes, it is. Yeah, sorry. Yeah.
Just wanted to clarify. Thank you very much. Ravi, you want me to go for the first this time?
Yeah, I guess we could split exam and labs, whichever is your preference. Yeah.
Sure, I'll take the exam then. So when I first heard the exam vitals, my spidey senses started tingling because this is concerning. I know technically by definition, like doesn't have a fever, but I think some in the elderly, the fever curve does drop off a little bit, where they don't tend to have, they usually have a lower body temperature. So I would always like to compare, like, outpatient vitals to see where does their temperature usually run. And plus him having HIV, I think that for me, 99.9, I wouldn't ignore it. And then obviously confounded with the tachycardia and the low blood pressure and the tachypnea, sure, he's satting room air right now, but these patients can deteriorate pretty fast. And I think I'm very concerned for sepsis at this present time for some form of infection. Now, the question is, we don't have Reza here to do where did it come from? Where did it go? That's typically for Staph aureus, but still, where's the source of infection here? And I think right now, with his history, you would have to consider GU infection, at least for now, especially with the nitrites positive. I'll leave that to Ravi to discuss it further. But tachycardia, shallow breaths, tachypnea, these are all findings of someone that's really sick, and his body is trying to compensate. I will say the spinal tenderness. Sorry, you said there was no spinal tenderness. Is that correct?
It was
okay.
Correct. No spinal tenderness. Yeah.
Okay. So how sensitive or specific that test is, honestly, I don't know on top of my head. But if the patient doesn't have spinal tenderness, that does make me a little bit less concerned for like a spinal abscess or lytic lesion or a osteomyelitis. However, in a patient who doesn't, who is at risk for infection, if his paraspinal muscles don't, that's the soreness or the sudden onset of pain doesn't improve, it wouldn't exclude me to get an MRI or further imaging, even the CT of the back, just to make sure we're not missing like an abscess or lytic lesion because of patient's background. But at least for now, looking at the physical exam, no spinal tenderness. We can start this patient, get blood cultures, get urine cultures, start them on broad-spectrum antibiotics, and we don't have to rush for a MRI or CT of the back, at least at this present time. And I'll turn it over to Ravi to go over the labs.
Yeah, Jas, I appreciate you following the possibility of an infection. I've kind of been going, I guess, part of the aliquots, like trying to decipher, okay, the history, the meds, and so on. But then, in the grand scheme of things, what could be causing this presentation? And as we make we expand our problem representation, you highlighted this patient is immunocompromised. So I think with the age, diabetes, and HIV, that's like a threefold blow to this patient. And we must consider infection in spite of a patient having a fever. But the temperature is you could say low grade, it's 99.9. So he's trying to mount a fever, but we have a pretty generous white count here. And I guess that does support your hypothesis of likely infection. But we do actually also have to pay respects to inflammation. Could this be an inflammatory condition as well? The sodium is low. I see it's highlighted. I think we do have to figure out what is probably the cause of this pain and so on, and that might actually allow us to understand why the patient is hyponatremic. If this patient just had hyponatremia, we would have to order at least the serum osm, urine osm, urine sodium as well, and decipher what exactly is the cause of his hyponatremia. But I think there's a flavor of hypovolemia, dehydration in this patient. The creatinine is up. There's the bicarb is down. There's usually we look for alkalosis, but I think if we calculate the anion gap, it's normal. So NAGMA, you have to start thinking about is the patient having any diarrhea? In this case, could it be the diuretic? There is a slight lactate elevation, which usually would give you a little HAGMA, but it's just a tad bit over 2. And then moving to the urine analysis, what can I really integrate into supporting our hypothesis of a potential infection? Yeah, the UA is abnormal. We have to be careful with this population of patients. He is, like I mentioned, and Jas has mentioned, that he's immunocompromised. So it's not uncommon to have asymptomatic bacteriuria, but in this case, with being immunocompromised, he's probably not able to recognize the inflammation and say, hey, doc, I'm having the usual, the symptoms of dysuria, urgency, frequency, burning, and so on. We ask patients. And then if you don't have the constellation of signs and symptoms, we label that asymptomatic bacteriuria. But in this case, I think we do have to worry about infection, a UTI, and likely it becoming complicated. And this CVA tenderness, is that a signal for pyelonephritis? Usually, what did Reza mention last week? There was a case, and he's mentioned UTIs, cellulitis, simple, don't cause white count elevations because they're sort of at the distant sites of the body. But when you have a white count, especially in this immunocompromised patient, this 15 would be 20 or 25 in you and me, Jas. Maybe this is indicating an upper urinary tract infection, a complicated urinary tract infection, like a pyelonephritis, like a perinephric abscess, like a UTI plus bacteremia. So I'm right there on the sepsis infection train there, along with your train of thought there. But bilateral, what's confusing me is bilateral pain. It's sort of like you don't get bilateral cellulitis, right? So I've never seen a bilateral pyelonephritis. If this is a case of bilateral pyelonephritis, Erin has a case she can actually present as a case report. So it's rather unusual to have bilateral. So then we might have to also focus our attention to what's central in the retroperitoneal region. So again, the spine. If the spine was involved, I would wonder, like, if there was a myelitis, would there be neurological deficits? The pain is excruciating with transverse myelitis or myelitis. If there was something abutting the spine, you'd look for radiculopathy. We're not getting any sense of radiculopathy or peripheral nerve involvement. So I would say, yes, CVA tenderness is remarkable, and imaging, just like yesterday's case where sometimes you're not looking for something, but imaging in that area might clue you in. Getting a CT might help us identify something that's there. So I can't really pinpoint or put a pin in like it is this that's causing this, but I think imaging is definitely necessary at this point to try and focus our attention on what's in that retroperitoneal space, what could be causing this excruciating pain. Anything come to mind, Jas, before we move back to Erin?
No, I agree. The bilateral flank pain makes me really hone in on the paraspinal muscles. I actually kind of looked it up. It's interestingly, spine tenderness on exam palpation has a reported sensitivity as low as 20% in affected patients with spinal disease such as osteomyelitis or abscess. So I think the exam is not enough to reassure me. I'm going to post that in the chat too, so for anyone that missed it. But you know, I agree with you. The bilateral sense like aspect of it does not make sense to me, and I would like want to explore it further with imaging.
Yeah, I just want to highlight Noah has joined, and I think he hasn't been here for a bit, but he interestingly did note about adrenal insufficiency. So adrenal insufficiency would give you hyponatremia, could give you abdominal pain, could give you back pain, can mimic a number of things, give you a rash, and also give you I think it's usually, a non-ANGAP metabolic acidosis, which you have here. So something to think about. The blood pressure is low, is borderline low, lower limit of normal, systolic is 90, so the patient is right at that benchmark. But this patient is in distress. Like Jas had mentioned, tachypnea, hypertension, tachycardia, low-grade fever is a concerning sign. So there is something afoot here, but what exactly? So Noah, I just want to highlight, Noah had mentioned this can be a mimicker of infection. So adrenal insufficiency, always keep on the top of your radar screen as a mimicker. Back to you, Jas, and if not, we'll have Erin present the next aliquot. Back to Erin. Okay, Erin, all yours.
Okay, I love that discussion. I'll give you guys a little bit more information from kind of day 0.5 to 1 of admission into day 2. So we got some urine cultures back, over 100,000 colony-forming units of E. coli, and blood cultures came back very quickly, 4 out of 4 bottles, also E. coli. He had a procalcitonin of 5.25. Luckily, at our institution, we get those back pretty quickly. He continued to, I'll describe his back pain a little bit more because this is actually one of the most difficult parts of the case for me. It was just really teasing out exactly what it was. So around day 1.5 of admission, his lower back pain and side pain got a lot worse. So the pain is worse when he kind of like twists from side to side. And then he also noticed that like he, more than before, like when he gets up and lies back down is like when it really starts hurting. So we were also initially worried about kidney stones and kind of imaging the back. So we did get a CT, abdomen, pelvis, and lumbar spine, but these were non-contrast initially because of the kidney stone protocol. So it showed no stones, but it did show mild bladder wall thickening to indicate cystitis, and then a possible superficial anterior abdominal wall fluid density, 3.6 by 1.4 centimeters, possibly a post-procedural seroma. We later went and asked him about this, and he said that's around the site where he injects his insulin. So at first we kind of, got really worried about it, but then after learning that, we kind of figured it was more of a seroma. And then his CT lumbar spine showed no acute fractures. It shows multi-level lumbar spondylosis and then degenerative changes contributing to severe spinal canal narrowing, especially at L3 and L4. So we had started him on Vanc and Zosyn for the sepsis, given him lots of fluids. And then actually I had performed a rectal exam because we were worried about prostatitis. He did not have a tender prostate, but like some of you guys had mentioned, I get the feeling that he doesn't have a great sensation in his like pelvic area. He's not really, he said he is having a little bit of incontinence, but he's not really like able to feel that well in that area, and could be due to his HIV, could be due to like longstanding diabetes and diabetic neuropathy, which previously his diabetes was way out of control. Recently gotten better. So I did do a rectal exam. He didn't have any tenderness though, but we did order a PSA, and his PSA was 16.27, and we don't have any sort of baseline on that. So we kind of, at this point, we're suspecting that it could be cystitis or pyelonephritis, even though we don't have any, CT imaging with contrast. That was on the differential. And then, of course, complicated from the bacteremia. And I'll stop there, but I will say that I guess, leading into the next aliquot, just considering that over the next few days, his white count continued to actually get worse little by little. It went up from like 15 to 16 to 17 to 18 over the next few days, despite us putting him on vancomycin at first and then eventually Unison. And then his back pain continued to get worse. So I guess I'll leave that aliquot there.
Yeah, I just wanted to jump in. Erin, this is a remarkable case. This is actually something I come across when I'm on the floors, that this is very common. I mean, E. coli grew out that up to 95% of urinary tract infections, simple urinary tract infections, will be E. coli unless somebody has had recurrent UTIs and has formed ESBL variant requiring a carbapenem. So we're thinking, if you think about, are we appropriately covering this patient? And that's where our carbapenems come into play. Otherwise, we usually reserve them for patients with significant toxicity. They're in the ICU, needing broad spectrum coverage, anaerobic coverage, gram-negative coverage, pseudomonal coverage. It offers everything except ertapenem doesn't cover pseudomonas, so we have to always anticipate that when covering recurrent patients with recurrent infection. So, but here we have E. coli, and it is commonly seen. And then the imaging without contrast, I would have anticipated the imaging, at least without contrast, you still would be able to see the typical perinephric stranding in the fossa, the bed where the kidney is housed in the retroperitoneum. So, but other structures that may not be seen, maybe we do need contrast in that case. But at this point, I think, yeah, we have a common organism. It's not sticky like staph, so we don't have to worry about a spinal abscess or epidural abscess or osteomyelitis of the spine, something of that nature to explain this pain. But I think moving back to what Jas had mentioned, pyelonephritis again, yes, we have the high white count, the patient's very sick. The tachypnea, though, yeah, I guess sepsis can cause that. A little acidemia can cause that. But, and there's no signal in the lung, there's no cough, no wheezing, no congestion or anything like that. But with this white count that Erin's mentioned getting worse and the patient starting to look worse, what do you think, Jasper? How would you approach that? This is definitely what we see, and this is what we always have to be prepared for. So a lot of learning for those in attendance today.
Yeah, no, I agree. This is like, we don't know what the end diagnosis is, so it may be something with esoteria, but at least right now, this is very common in bread and butter hospital medicine. So thank you again, Erin, for bringing this case to us. Also just shout out to both Vijay and Parisa. That whiteboard just looks jam-packed, and your efforts are heroic today, especially with Erin's case with a lot of details. I looked it up while Erin was presenting this, and CT can miss spinal infections up to, well, it's sensitive of 79%. So it's not terrible, but with this bilateral pain, could he just have hyperalgesia in the setting of sepsis from this bacteremic source? Yes, very possible. But you would expect the back pain to improve with Zosyn, because Zosyn would cover E. coli, unless, like you said, Ravi, this was ESBL and needs meropenem. But if those sensitivities come back and Zosyn is susceptible, then I would be concerned for source control, or a lack of source control here. Like, is there an abscess or is there a osteomyelitis lesion? And I'm trying to connect those two. Is this because this patient had such profound bacteremia, 4 out of 4 bottles, that it started invading into the spine? Or this is more like esoteria, but it's kind of a pretty cool phenomenon that Reza and Ravi taught us, is that through the Baston's plexus did the infection go from the bladder and move itself into its way to the spinal canal. So, and lead to like complications there. So right now, I think the way I would summarize it is if the patient is getting worse despite broad spectrum antibiotic for a presumed pyelonephritis that led to sepsis, I would say that's a little weird that the patient is not getting better with broad spectrum antibiotics. And I would start looking at the antibiotic failure schema. And I would say, is this the wrong bug? Doesn't seem like it because it's going E. coli, but it may not be sensitive. So let's wait for those sensitivities. Is this the wrong drug? Less likely it's broad spectrum unless we're missing a fungal infection. Or is it the wrong diagnosis or non-infectious? I don't think we're there yet. And the other thing is there a concern for lack of source control? So I'm like getting a little bit more, I kind of want to get more investigations, especially if the culture's data shows that this patient should be susceptible to the antibiotic that he's getting.
Yeah, Josh, that's a great thought. I think I loved you. That was exactly what I was thinking, that schema of a patient getting worse on antibiotics. I mean, that what Erin had mentioned, the vanc and zosyn or the vancomycin and piptazo will cover pretty much everything. Probably except, VRE is covered, ESBL isn't covered. And then any MRSA that's not sensitive or vancomycin resistant MRSA or intermediate resistant MRSA. But I think source control is key. And I kind of mentioned E. coli is not typical. What do we usually see? Staph causing abscess, endocarditis, and so on. But I guess through the transition through the Baston's plexus, like you mentioned, and this patient already has disruption of anatomical layers within the spine. He has all this other pathology in the spine. So it's very easy probably for E. coli to take up residence in the spine and cause maybe abscess, osteomyelitis, and so on. So I think shifting from pyelonephritis, and we're like, bilateral pyelonephritis doesn't make sense. So maybe something central, and especially when Erin mentioned he's moving, he's trying to find a comfortable position. And these kind of things, they're not like open to the body where you have massive inflammation and this abscesses or this infection is screaming to all the inflammatory cells, saying, come here, come gather here, and let's have a Coachella in the spine here, right? So this patient's, it's been building up for a while. This patient's like feeling like, I feel bad, something's going on. So this thing is sort of starting out as this indolent, slowly accruing infection, and suddenly it's come to a head, and now he's presenting with all this manifestations. But whenever you have bacterium, you have to wonder about that. And I just love you mentioning or reflecting on that Baston's plexus. There's a straight, like when you go down to any city, you go on a HOV lane or you go with the regular traffic. This is a HOV lane straight to the spine. Maybe that's what we're dealing with. So back to Erin.
Yeah, I mean, you guys basically clinched the diagnosis. So I'll just go ahead and review everything else that happened. So over the next couple of days, his back pain got worse, his white count was still worse. His tachypnea did get a little bit better. And like I mentioned, we did end up getting a CT PE and CT abdomen pelvis as well with contrast, because we just wanted to get a better look. And we didn't see anything that new compared to the images without contrast. But actually, day 4 of admission, he developed bilateral lower extremity weakness. And it was at that point that we decided, okay, we really need to get this MRI. So it's a little bit tough to get MRIs here at our institution. And so that's kind of why we didn't order it earlier. Usually there's like a very, very high, level threshold to order them because it's a very limited resource. So, there are like 3 other patients on our list that needed MRI. So we were thinking, okay, maybe this patient can wait a little bit. But when he developed a lower extremity weakness, we said, we've got to get the MRI stat. And then we ended up finding inflammatory changes involving both psoas muscles with a 2 by 3 centimeter abscess on the right. And then heterogeneous epidural enhancement at L3 and L4 may represent a phlegmon or engorged epidural vessels, and non-specific bony signal alteration could represent spondylodiscitis or be degenerative. but also could represent osteomyelitis. So you guys were absolutely right about the Batson's plexus. That was actually one of the teaching points that I had when I presented this case to people at my institution. And this is why I love clinical problem solvers, because, we all know like a different subset of information. And when I presented this to, some of the faculty and residents here, none of them had heard of the Batson's plexus. And I just found it amazing that you guys all knew it already. But yeah, it's very common for UTIs to kind of travel through that venous plexus to the spine and manifest as osteo. And I just wanted to kind of highlight briefly before you guys make your final teaching points too, some of my personal takeaways from this case. Again, we love cases that are sexy with, like opportunistic infections and stuff, but I just love this case because it's just like, to me, it represents like what medicine is. Daily evolution of the patient's symptoms, daily like reevaluation, reconsideration. And I think that in the beginning, I personally anchored a lot on the pyelonephritis and the flank pain. And I don't think I asked specific questions about the back pain, because especially in our veterans that have chronic back pain, it's easy to kind of in the back of your mind just say like, okay, they're probably just, their back pain is worse because they're sick, but they always have back pain, they have degenerative disease. So I think back pain is a very, very like nuanced, and it's important to tease out. I also will say that this case really challenged me to think more whenever you document or say that somebody has a UTI, to really like kind of take that out of your vocabulary. Always try to say like, is it cystitis? Is it prostatitis? Is it urethritis, or is it pyelonephritis? And I think if you challenge yourself to do that, you'll really get in the habit of like thinking about the anatomy and thinking about what kind of complications there can be. So for example, pyelonephritis can lead to perinephric abscesses. Prostatitis can lead to, rectourethral fistulas and more abscesses in the area. Urethritis, you always have to think about STIs in younger patients. So I think really localizing, like I really made this case kind of my decision to never use the word UTI again, and always try to at least guess where the infection is. And I think that that will really like help me be more detailed in the future and not miss diagnoses. And then just one other thing that I wanted to mention as well, you guys were all talking about the sensitivity and specificity of the CT scans. Yeah, he had a CT scan of, and it didn't pick up on the abscess. Now, he didn't have the CT scan of the spine with contrast, but, I was reading some of y'all's comments saying the sensitivity is as low as like 20%. And even, we're traditionally taught about point tenderness and spinal tenderness as being like, pathognomonic for osteo as well. But this gentleman never ever had that. And I think you can use that as a clue, but you should never rule that out. So those are kind of my personal teaching points, but Jasdeep and Ravi, I'll let you guys kind of share yours as well.
I just want to say, Erin, remarkable presentation and just amazing workup. This is exactly what I would do. And I have faced such cases, maybe with not epidural abscess, maybe a pyelonephritis or perinephric abscess, but I've never seen this with E. coli. This is super rare. You have a very rare case, and this is something I would get out there, publish and show, because again, the usual teaching is E. coli usually doesn't cause this much pathology in the back, but this is remarkable. We do not usually see this. And I've never seen a case like this before, but this is what we do. This is bread and butter. But what I think, like Jas had mentioned, endpoint diagnosis, just not performing premature closure. Okay, we found E. coli in the blood and we put them on antibiotics and maybe narrow the spectrum. I would have put them on ceftriaxone and then leave it alone, but then this patient's getting worse. And usually we consult ID for Staph aureus, the morbidity does decrease. But in this case, you're like, gram-negative rods, do we even consult ID for this? I think if the patient's not getting better, it would be helpful, just so that they can help us with the appropriate management of the patient so they don't get further toxic and end up with septic shock. But a lot of teaching here, and I really appreciate, really honored that you brought this case to us and you cared to share it with us today. Thank you. Jas?
No, I wholeheartedly agree with everything you said, Robbie. The only thing I will say, Aaron, if you can find time in your busy schedules to come back and do more cases like these, we would happy to have you here. This was phenomenal. Learned a lot, and definitely was a challenging case, but like I said, challenging in the way where uh, something that we will see, not particularly exactly with like this, but very similar cases.
Thanks so much. I would be honored to present more cases. I love doing case discussions.
We have
I'll just
Parisa.
mention one more thing.
Oh, sure. Go ahead.
Oh, sorry. Somebody was talking, I just thought it was interesting and more for personal interest. Somebody was talking about RTAs in the chat. He actually ended up, his bicarb got lower and lower as well as the days went on. And we actually thought that he had a type 4 RTA from his tenofovir, which is one component of his ART. So we actually did consult ID and they actually switched him to Biktarvy, which also has tenofovir, but it's a much lower dose. So whoever picked up on that and was discussing that was very astute. I just, excluded that obviously because it wasn't as relevant to this case. But
Oh, wow. We could make this a whole RTA talk too. So yeah, amazing. Kudos to whoever mentioned that. We have the wonderful Parisa who's going to present the teaching points. Take it away, Parisa.
Thank you, Erin. Such an amazing case. And thank you, Dr. Ravi and attending Jazz for guiding us through all the diagnoses. I learned a lot today. We started with a patient who was elderly patient who were immunocompromised and had a subacute onset presentation of generalized fatigue. We know that it is a non-specific finding, but we know that in patients who are immunocompromised, even low-grade fever is a red flag. And when we are facing sudden onset presentation, we need to think about infection, recent injury, or maybe musculoskeletal issues. We know that HIV will cause opportunistic infection when the CD4 is diminished. And we know that patients with HIV are more prone to infections like UTI, pneumonia, pyelonephritis, osteomyelitis, and also they are prone to cancers like lung. For flank pain, we could have an anatomic approach. We need to think what organisms are there. Is this any problem in the paraspinal muscle? Is this kidney problem, including stones and infection? Or is it nerve, muscle, or it could be maybe aorta problem? When patient is having trouble in mobility, specifically in elderly patient, it might be through the polypharmacy, all the medication they are on, which could cause myalgia and rhabdomyolysis. We need to make sure about the compliance of the medication they are. For example, in patients who have HIV, we need to make sure that are they compliant to the ART treatment. About the side effect of the medication, we learned that a statin could cause myopathy in two mechanisms. It could cause direct muscle toxicity, which is called SAM, statin-associated myopathy, or it could cause immune-mediated necrotizing myelopathy, which is more aggressive form. About HCTZ, we know that which is causing volume depletion and it might provoke prerenal azotemia in the patient. When we are talking about weakness in a patient, we need to ask more detail about their baseline daily activity to interpret the finding in our own word. We know that in elderly patients, we have a drop in the fever curve, and they usually have lower body temperature. Because of that, even a slight elevation in the temperature could count as a fever. This patient has tachypnea, shallow breath, elevated white BC, which all could be cause of the infection. And when we are having lower back tenderness, we need to think about imaging to rule out any abscess in the region. CT or MRI could help us. We know that CT is 79% sensitive. When we are facing UTI and cellulitis, we know that this might not cause severe leukocytosis. Because of that, even a slight amount of the elevation in white BC could guide us through complicated form of the UTI. About the mimickers of lower back tenderness, we have transverse myelitis, which could present with excruciating pain, plus weakness and bowel and bladder problems, and also adrenal insufficiency, which could present with hyponatremia, hypotension, back pain, abdominal pain, and non-anion gap metabolic acidosis. We learned that spine tenderness on example palpation, which is 20% sensitive for spine disease like abscess and osteomyelitis. In terms of organism, we know that E. coli is usually 90% responsible for causing UTI, which will be covered by zooxin, and staph is usually causing a spine abscess, epidural, and infectious endocarditis. When we have a patient which is on extensive antibiotic therapy, but it's not getting worse, we need to activate antibiotic failure schema. We need to think about wrong bug, wrong drug, wrong diagnosis, and we need to think about lack of source control. We learned that UTI could travel through venous plexus and spine and psoas abscess. We also, Erin taught us that UTI is a really common term. We need to break it down to cystitis, prostatitis, urethritis, and pyelonephritis. Which of those has a specific complication, like prostatitis could present with rectourethral fistula. Thank you so much for this amazing session.
Teresa, that was such an amazing teaching point. So organized, so clear, and captured basically all of the main points from this case, which actually was a lot. And Vijay, I just want to say thanks for doing such a great scribing job as well. And lastly, but certainly not least, Erin, thank you again for presenting such a great case. And we're happy to have you anytime you can make time for us. So thanks everyone for joining. I hope you all have a great Thursday.